All right, welcome to this explainer. Listen, if you're a young doctor stepping foot into the intensive care unit for the first time, let's be totally honest, it can be incredibly intimidating. The alarms are constantly blaring, the patients are literally the sickest in the hospital, and the sheer volume of data, combined with that endless symphony of beeping pumps, yeah, it can make you feel like you've been dropped into an orchestra tuning up in the dark. The cognitive overload is massive. But hey, don't worry, because that is exactly why we're here today. In this explainer, we are going to build a mental scaffold together, a highly structured framework based on critical care pearls to help you not just survive, but truly master your ICU rotation. We're going to break down all these complexities into manageable daily actions.
We've got a lot to cover, so here's our roadmap for today. Rounding with fast hugs bid. 2. Managing the difficult airway. 3. Ventilator and vasoactive basics. 4. Mastering ABG analysis. And 5. Nutrition and long-term care. Let's jump right into section 1. Rounding with fast hugs bid, your daily anchor.
You know, in the ICU, the little details absolutely matter, and missing even one can be catastrophic. So to manage that massive cognitive overload, we anchor our entire day on a really systematic checklist. Fast Hugs Bid isn't just a catchy phrase, it's a mnemonic that lets us verify we're delivering comprehensive evidence-based practices to every single patient on the unit. Think of it literally as your mandatory pre-flight check before takeoff. It covers the whole shebang, everything from feeding and analgesia to sedation, head of bed elevation, ulcer prophylaxis, glycemic control, and a whole lot more. Let's actually pull out a few of these critical letters to see how they apply to your daily rounds. Starting right at the top with F, feeding. Now, I know nutrition is kind of often an afterthought for junior doctors who are laser focused on acute crises, but it really shouldn't be. You have to critically ask, what diet is the patient getting? Can we optimize it? And most importantly, if they're currently NPO or nil by mouth, do they truly still need to be? Because if they're projected to be NPO for an extended stretch, you need to proactively start thinking about TPN or total parenteral nutrition. Early enteral feeding is directly linked to lower mortality, so don't let your patients starve just because you're distracted by a ventilator, right? Moving on to A for analgesia. Let's be real, having a plastic tube down your throat is incredibly painful and uncomfortable. Your goal here is to constantly evaluate if their pain control is adequate. But even more than that, as a modern ICU practitioner, you've got to ask if non-opioid adjuncts are being used. Like, can we add oral analgesics instead of just relying solely on heavy IV infusions? Managing pain effectively actually prevents the patient from fighting the ventilator, and that makes oxygenation so much easier to control. And let's actually skip ahead just a bit in our mnemonic to G, glycemic control. So here's the thing. Maintaining adequate blood glucose levels is crucial. Critical illness induces massive stress on the body, which leads to insulin resistance and hyperglycemia even in patients who aren't diabetic. Your general target here should be 6 to 10 millimoles per liter. Now, while the absolute optimal targets are still kind of debated based on pre-admission control, we know for a fact that wildly fluctuating glucose levels are universally harmful. Fast Hugs Bid ensures you literally never forget to check this. All right, moving into section 2, managing the difficult airway. High-stakes interventions. Now that we've got our daily rounding anchor, let's zoom in on one of the most adrenaline-pumping clinical situations you're going to face, the difficult airway. Airway management in the ICU is just fraught with peril. These patients are physiologically unstable and have very, very little reserve. So your absolute top priorities are oxygenation and first-pass success. Repeated attempts, they just lead to swelling, bleeding, and hypoxemia. To get that first-pass success, you have to anticipate both anatomic and situational risks before you even pick up a blade. Rely on evidence-based tools like videolaryngoscopy and always have supraglottic devices ready as a backup. But here's the real secret, guys. The gear doesn't save the airway, the team does. You absolutely must practice closed-loop communication and maintain shared situational awareness in the room. State your plan out loud, verify the nurse has the paralytics drawn, and confirm everyone knows their role. Okay, section 3, ventilator and vasoactive basics, your life support essentials. So, the tube is in, the airway is totally secure. Now what? Well, we move to the next vital step, actually hooking the patient up to the machines that will keep them alive. Setting up a vent doesn't have to be a total mystery. For your initial settings on a newly intubated patient, just follow these 3 rapid-fire steps. Step 1, select Assist Control, or AC mode. This gives good comfort and easy control over crucial physiologic parameters. Step 2, always start your FiO2 at 100% and then titrate it down based on pulse ox or blood gases. And step 3, this one is critical, set a low tidal volume of 6 to 8 milliliters per kilogram of ideal body weight. Low tidal volume ventilation is lung protective. High volumes actually increase shear stress in the alveoli and actively induce lung injury, which we call VILI. Building on those initial settings, let's look at baseline parameters.
You want to set an initial respiratory rate of about 10 to 12 breaths per minute to keep them comfortable. Start with a low PEEP of 5 centimeters of water, titrating upward for oxygenation, but pay close attention to blood pressure because high PEEP can actually decrease venous return. Also, make sure your initial flow rate is at or above 60 liters per minute. Why? Well, because you want to give the patient plenty of time to exhale. That prevents air trapping, also known as auto PEEP, which can be absolutely devastating. Oh, and note one massive caveat here. If your patient has severe metabolic acidosis prior to intubation, you must match their pre-intubation minute ventilation, where they will code.
Now, when it comes to vasoactive drips, there is a hard and fast rule you just have to follow. Notice that dopamine and epinephrine are strictly designated as central line only. While it's generally recommended to have a central line for all vasoactives in the ICU just to ensure stable delivery, pushing dopamine or epi through a peripheral IV is a massive, massive risk. If that IV infiltrates, those powerful vasoconstrictors will leak right into the surrounding tissue, causing severe local ischemia and potentially tissue necrosis. Knowing this inside and out will literally save your patient's limbs and your medical license. Which brings us to Section 4, Mastering ABG Analysis, getting that metabolic picture. So, the life support machines are running, but this is definitely not a set-it-and-forget-it situation. We have to precisely monitor our patient's metabolic status, and the absolute gold standard for this is arterial blood gas analysis. An ABG gives you a huge diagnostic advantage over basic pulse oximetry. Look, the pulse ox is great for a quick oxygen saturation reading, but it tells you absolutely nothing about the patient's ventilation, their carbon dioxide levels, or their acid-base status. A properly drawn ABG, which, by the way, always requires an Allen's test first to ensure collateral blood flow to the hand, gives you the PaO2, the PaCO2, the pH, and bicarbonate levels. It's the definitive tool for detecting really subtle acid-base imbalances. In the ICU, we don't guess if the ventilator is working. We use the ABG to directly guide the titration of our mechanical ventilation. To really drive home why mastering ABG interpretation matters so much, check out this statistic. Research shows that among ICU patients suffering from acidosis, mortality is significantly higher for those with metabolic acidosis compared to respiratory acidosis. In fact, patients with metabolic acidosis face a staggering mortality rate of 75%. 75%. That is a terrifying number. Rapid detection and intervention through really diligent ABG analysis isn't just some textbook exercise. It's an absolute necessity to catch this lethal derangement early. Finally, let's hit Section 5, Nutrition and Long-Term Care, taking the holistic view. Let's zoom out a bit from all those acute alarms. Surviving the ICU? That's really only half the battle. Check out the stark contrast in nutritional management between these two phases. In the initial ICU phase, a patient's metabolism is characterized by severe inflammation and catabolism. Here, you've got to progress feeding slowly. Aim for only 70 to 80% of their energy expenditure. Overfeeding early on actually increases mortality, and you must closely monitor for refeeding hypophosphatemia. But once they transition to the chronic or post-ICU phase, you have to completely flip your strategy. Now you need highly aggressive protein administration, targeting at least 1.3 grams per kilogram per day. And this has to be combined with physical exercise and high-protein oral supplements once the feeding tube is out, just to help them rebuild all the muscle they rapidly lost while bedridden. And all of this really leads us to the ultimate goal of modern critical care. We are actively fighting to prevent post-intensive care syndrome, or PICS. This is a devastating decline in physical, cognitive, or psychologic function in ICU survivors. It's exactly why the Society of Critical Care Medicine pushes the ICU Liberation Bundle, the ABCDEF bundle, which covers things like awakening trials, breathing coordination, delirium monitoring, and early mobility. As a doctor, everything you do, from your morning fast hugs bid checklist to lung protective ventilation, is intended to minimize iatrogenic harm so the patient doesn't just survive the unit, but actually goes on to live a normal life. So, as you lace up your shoes for that next ICU shift, I want to leave you with this final, provocative thought. As you adjust that ventilator or write the order for that vasoactive drip, ask yourself, how will your daily ICU interventions today prevent post-intensive care syndrome tomorrow? Are you just treating today's numbers on a screen, or are you actively shaping your patient's long-term quality of life? Keep that framework in mind, trust your checklist, rely on your team, and you are going to thrive. Thanks for joining me on this explainer.